Sure. So I was asked to talk a little bit about where PrEP fits in uh, the overall strategy. Um, so, as many of you will know, there's a national HIV/AIDS strategy that is produced by the Office of National AIDS Policy in the White House, and they updated it for 2015 to 2020. So we generally refer to this as NHOS 2020. And in it, there are three key goals. One is to reduce the number of new HIV infections. Goal 2 is to increase access to care and improve health outcomes for people living with HIV. And goal 3 is to reduce HIV-related health disparities. Both 1 and 3 are intricately attached to efforts to roll out PrEP in the United States. And while in 2015, in the original 2010 to 2015 plan, there was absolutely no mention of PrEP, in the current plan, it says full access to comprehensive PrEP services for those for whom it is appropriate and desired, with support for medication adherence for those using PrEP, is to be expanded. But we do want to remember that PrEP is only one of several very effective methods that we have to reduce HIV infection. And in the first few years, decades of the HIV epidemic, we were pretty much limited to the behavioral interventions, so condoms, substance abuse treatment, and sexual behavior change. But in the last decade, we have seen convincing evidence of the effectiveness of male circumcision, NPEP, treatment as prevention, and PrEP. And so we need to be sure that all of these options are available to as many people at risk as can use them. It's worth noting that clinical HIV prevention is not new and is not dependent on PrEP. It predates PrEP. So periodic HIV testing for patients in care, referral or provision of antiretroviral therapy for HIV-positive persons, conducting periodic sexual histories and periodic STI screening, and referral or provision of behavioral health care, all of these are clinically based processes that were in use long before PrEP became available, and in fact are a good foundation for a PrEP program. People were talking about treatment as prevention, and while treatment as prevention is highly effective to reduce onward transmission of HIV infection, it's worth noting that there still remains a role for protecting the negative partner in sexual encounters with an HIV-positive person. And the reason relates to the cascade. Normally you see the cascade as in the other direction. So these are the number, there are of all people who are estimated to have HIV infection, 87% are estimated to have diagnosed infection. And it goes all the way down to 30% who are on ART and virally suppressed. At the point that they're on ART and virally suppressed, PrEP probably has little to contribute to protection of the negative partner. If you're truly virally suppressed on a continuing basis, the risk of transmission to your partner is very low. However, if you turn that on its head and say, what proportion of people are not virally suppressed? What proportion of people are not diagnosed, are not in care? What you can see in the blue line is those are all people who would benefit from PrEP should they encounter an HIV-positive person in one of these categories. So until we get higher coverage of viral suppression, there is a significant role for PrEP, and we should not be looking at these as an either-or phenomenon. As somebody said, we need to encourage both treatment for positives and sustained adherence to their medications, as well as for people who are starting PrEP. When we think from the national level about how we're going to support increased utilization of PrEP, we have had to think about the different perspectives and needs of our key stakeholders. So health departments have one set of issues that they need help to address. So, for example, what does surveillance and evaluation look like in PrEP as it's rolling out? Patients have their own concerns. So those are things like whether they can access care, how much it's going to cost, how complicated this treatment is going to be. Community-based organizations are challenged to bring the knowledge that they already have and update it with the appropriate knowledge of these interventions so that they can participate in supporting patients, but also in educating potential users. And then, of course, clinics have a whole variety of issues related to whether they see PrEP as congruent with their mission, whether they think providing PrEP will improve or challenge their practice reputation. So there's a lot of different things that we've heard from our stakeholders that they need help with. In general, because this is an intervention for people who are uninfected, there are a few categories of people who we think are ideally situated to provide PrEP because they see uninfected people who have risk behaviors. That includes primary care providers, STD clinic providers, drug treatment providers, as well as HIV care providers. HIV care providers, because they are used to antiretrovirals and dealing with some of these issues, have been in the forefront of the delivery of PrEP. And now we're in the process of trying to figure out how to broaden access to some of these other provider groups. This is just an example. For example, if you say, well, people who are at STI risk are obviously at risk for, and are negative, are obviously at risk for HIV infection and should have access to PrEP. So where is it that people get their HIV tests? We think automatically of STD clinics, but this study, which really did a good job of identifying all the different sources of care, what you'll see is that they called them venereal disease clinics in those days, but STD clinics provided less STD testing than family planning clinics, outpatient clinics, health department clinics, private physicians. So even though we think about it as it's an STD clinic place, there's much more than half of the testing goes on in primary care settings. This is more recent data where they stratified it by whether it was an STD clinic or a non-STD clinic. And again, you see the same phenomenon, that the non-STD clinic sites do the majority of the STD testing and treatment and diagnosis in the US. So we can't just limit ourselves to STD clinics. So what do primary care clinicians know about PrEP? In order for them to deliver it, they have to know it exists. And we've been doing surveys on a national panel of doctors called DocStyles for several years. And what you can see is that even before the first trial result in late 2010, that there were about a third of primary care practitioners who had at least heard about using antiretrovirals for prevention. And it's been steadily going up. Unfortunately, it's only gone up to about 65% in 2015. So we still have a lot of work to do to make sure that primary care clinicians even know such a thing is possible for their patients. On that survey, we also asked them if they weren't providing PrEP, what CME they wanted, what topics they wanted. And what you can see is almost nobody said none. I think it was 17% said, no, I'm good. It was more than 50% who wanted each of the other topics there. So they might be aware of PrEP, but they don't think they know what they need to know in order to prescribe it. In part to address that, CDC has funded something called a PrEP line. In the early days of antiretroviral treatment, we were in the same situation. There were a lot of providers out there who weren't quite sure what drug to use, when, and how. And so HRSA set up an HIV treatment line. And then when we had perinatal prevention, we set up a perinatal line. And then when we had PEP, we set up a PEP line. So we have added to that a PrEP line, which is at the National Clinicians Consultation Center at the University of California at San Francisco. And they have a cadre of ID docs, family physicians, pharmacists, OB/GYNs, nurses, a whole variety of people who sit in a room about a quarter this size and just answer the phone all day and answer questions from clinicians about these things. So they're now able to do that for PrEP as well as the other things. So if providers are not sure, my patient is taking this drug, is this contraindicated, you can call them and they'll talk to you about it. My patient came in and they say there's good data that I can just take a pill before and a pill after. Is that true? Can I prescribe it that way? They can talk to you about what's the evidence and why you wouldn't do that. Managing PrEP in pregnancy, transitioning from PEP to PrEP, all of these are topics that they're prepared to discuss with providers and do at least telephone hand-holding. In addition, we heard from providers, I'm not going to ask a 45-question risk assessment. It's not happening. I'm too busy. I can't do it. Which we understand. And in research, we do that all the time. And we generate these long lists of things that are correlated with HIV infection. So instead, we said, look, when we're trying to figure out which of our patients may have an alcohol problem, for example, we would use the CAGE screen, 4 questions. And it doesn't tell us they definitely have an alcohol problem. It screens for those people we need to have a longer conversation with. And so we took large studies in which they asked behavioral questions and did HIV testing periodically over time. And we asked statistically what small set of questions that a provider could assess at a single visit, didn't depend on the patient coming back for a test result, et cetera. At time X, best predicted HIV infection at time X plus 1. And then we summed those over time and did, the manipulation to develop a screening index. So we have a screening index for MSM, which I think one of the previous presenters showed you. I think it's 6 questions. We pilot tested that with providers as well as with MSM, and it was interesting. The providers were happy with it because it was short and they could figure it out. The MSM were unhappy that it was so brief. They said, but you didn't ask me about this and you didn't ask me about that. It was kind of interesting. And then we did one for injection drug users. Both of these have been published, and you can download the scoring sheets and begin using them with your patients. We're also working on putting these into an app that you will be able to download. So you can pull out your phone, ask the 6 questions. It'll tell you what the score is. There's one for discordant couples that we've already developed that's way cool. That would probably be better on a tablet, because what that one does is it asks for some information, like 2 questions about the positive partner, 2 questions about the negative partner, and then 4 questions about sexual practices. So how often do you have anal sex? How often do you have vaginal sex? Of those times, how often do you use condoms? Blah, blah, blah. What it calculates for you is your lifetime, no, not lifetime, your 20-year, your 5-year, and your, I think it's 1 year risk of acquiring HIV infection, giving the risk profile that you've given. And then it shows you on these neat little pie charts what proportion of that risk is coming from each of your sexual practices. And we did it that way so that providers, or particularly counselors, nurses, case managers, could sit with patients and play with it and say, okay, your 1 year risk is 40%, not good. So which of these behaviors do you think you're capable of changing? Well, what if I went from using condoms none of the time to using them half the time? And the pie charts will change and the risk will change, and it'll show you what you've done to your risk. So a year from now, maybe, you'll be able to go to the App Store and download these.